Unit 10, Dissociative Disorders and Somatic Symptom Disorders. 10.2 Introduction. Have you ever felt as if you are dreaming, feeling detached from yourself or the things around you are unreal? Most people have such experiences occasionally and may feel detachment or alterations in their consciousness or identity. While such dissociative experiences are normal, they are extremely intense and disorienting to a few. They may suffer a loss of memory, their sense of reality, or even their identity, and may adopt a new one. These severe disturbances that can lead to functional impairments are termed as dissociative disorders. We may all occasionally wonder if we are unwell and take questions about our health to doctors, but some individuals may be preoccupied with their health or body to an excessive or maladaptive extent that their life is dominated by it. Such conditions are classified as somatic symptoms and related disorders and have the common thread of excessive response to physical symptoms or related health concerns. In this unit, we will learn about the various conditions that are classified under these two categories, their presentation, causal factors or mechanisms, and treatment. Historically, these two diagnostic categories have been strongly linked as they were found to have common features and were initially clubbed under the term hysterical neurosis or hysteria. These conditions were often presented with unusual phenomena that did not have a medical explanation, and theorists sought to explain them otherwise. The term hysteria is associated with early ideas that these disorders were the result of a wandering uterus or due to dramatic and histrionic behaviors that were considered typical of women. This terminology is no longer in use as it conveys prejudice and a stigmatizing attitude. 10.3 Dissociative disorders. Dissociative experiences, where one feels detached from themselves or their environment, were found likely to occur in response to extremely stressful, traumatic events. Such experiences of unreality are a psychological mechanism and need not be pathological at all times. Pathological phenomenon of dissociation may be characterized by a subjective loss of continuity in experiences or memory due to unwanted intrusions, b. gaps in memory, sense of identity or consciousness due to lack of accessibility / control of information or mental functions, and / or c. experiences of distorted perception of oneself or the environment in a disconnected manner. These experiences can be classified into two types: depersonalization and derealization. A loss of one's sense of themselves where they feel as if watching themselves and their reactions from outside is defined as depersonalization. Episodes of derealization are characterized by changes in the reality of the world around us, where objects may appear to be in different sizes or even people may appear changed. These episodes can contribute to serious disturbance in perceptions of reality, memory, and even their sense of identity. DSM-5 lists 3 major dissociative disorders. The following section describes their clinical features and aims to describe the causative factors and possible treatments. 10.3.1 Clinical descriptions. Depersonalization derealization disorder. Box 10.1, Case Study Depersonalization derealization disorder. Rahul, a 42-year-old man, walked in for a psychiatric consultation, appearing thin and tired. He reported that he has been almost constantly feeling spaced out for the past 20 years. When asked to describe what he meant, he said, "One day I was walking on the road and I suddenly felt as if I was looking down at myself from a balcony. Since then, I have had many such episodes and I never feel like I am completely back in my body." He was extremely afraid of his experience. He spends most of his days at home and has been unsuccessful at holding any job as he had multiple episodes or spent time worrying about his condition. He also had difficulties in his marriage as his wife was tired of dealing with his complaints about feeling spaced out. He had sought treatment multiple times in the past but felt that medications helped only a little. He was reluctant to try any new medication as he was fearful of any consequences. Chronic and distressing experiences of unreality that interfere with normal functioning are diagnosed as depersonalization derealization disorder as described in the case of Rahul, BAPCH 10.1. This is a relatively rare independent syndrome as depersonalization and derealization episodes are experienced by people with a number of other psychiatric conditions such as post-traumatic stress disorder, borderline personality disorder, somatic symptom disorder, substance-related disorders, schizophrenia and anxiety disorders. This essentially means that the individual's dissociative symptoms should not be better explained by another diagnosis as indicated in the DSM-5, BAPCH 10.2. This disorder was found to be affecting men and women equally, with 16 years being the mean age of onset. The onset of the condition tends to be sudden with a predominantly chronic course. BAPCH 10.2, DSM-5 diagnostic criteria for depersonalization derealization disorder. The presence of persistent or recurrent experiences of depersonalization, derealization, or both, depersonalization, experiences of unreality, detachment, or being an outside observer with respect to one's thoughts, feelings, sensations, body or actions, for example, perceptual alterations, distorted sense of time, unreal or absent self, emotional and forward/or physical numbing. Derealization, experiences of unreality or detachment with respect to surroundings, for example, individuals or objects are experienced as unreal, dreamlike, foggy, lifeless, or visually distorted. B. During the depersonalization or derealization experience, reality testing remains intact. C. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. D. The disturbance is not attributable to the physiological effects of a substance, for example, a drug of abuse, medication, or another medical condition, for example, seizures. E. The disturbance is not better explained by another mental disorder, such as schizophrenia or panic disorder. Dissociative amnesia. In this condition, the individual is unable to recall important personal information, resulting in a pattern of amnesia that cannot be otherwise explained as a medical condition or ordinary forgetfulness. Dissociative amnesia may leave a person unable to remember anything about themselves, and this pattern is described as generalized amnesia. This may be circumscribed to a specific period of the person's life, such as the last 6 months or a year. More commonly, the pattern is localized to a particular event or experience. In most cases, it is observed that the forgotten material is often associated with significant trauma or stress that is unprocessed, such as abuse, witnessing violence, etc. It can also be restricted to specific aspects of a traumatic experience that are selectively forgotten. Information related to a particular theme that is stressful for the individual may be forgotten in systematized amnesia, for instance, meeting a particular person. It is important that these symptoms lead to significant levels of distress or disturbance in their ability to function adequately in different realms of life, such as occupation or interpersonal interactions. It is also required to have these symptoms independent of other related diagnoses such as PTSD or neurological conditions such as head injury. A variation of dissociative amnesia, where the individual wanders away from their place of residence, is known as dissociative fugue, literally means flight. This is added as a specifier to a diagnosis of dissociative amnesia. Individuals often find themselves in a new place with no idea of how or why they got there, as seen in the case of Andra, Box 10.3. During this period, they may be unresponsive to the environment or may be confused about their identity or may even assume an alternate identity. Box 10.3. Case study: dissociative amnesia with dissociative fugue. Andrea, a 23-year-old female, once left her office where she worked as a chartered accountant by foot at the end of her day. She spent the next few hours walking around the city and eventually boarding a train to a neighboring state. She eventually found herself at a supermarket, disoriented. She was terrified as she was unable to remember why or how she had gotten there. According to her family, she had been missing for a few days and had no contact till she called them from the supermarket. From the day she had wandered off, she had been living in the other city without remembering any of her personal details as reported by people who had met her during that period. Dissociative amnesia usually occurs during adulthood and is the most prevalent of all dissociative disorders. Fugue states tend to end abruptly and the disruption in memory and identity that occurs is not always restored. Such episodes can also occur in dissociative identity disorder, a condition popularly and incorrectly named as split or multiple personality disorder in lay terms. Dissociative identity disorder, DID. Box 10.4, Case study: dissociative identity disorder. Sasha, a 25-year-old student, was brought to a hospital for episodes of poor memory and odd behaviors. She was confused about the recent past and thought she was in a place a few kilometers away from the hospital. During the process of the clinical evaluation, it was noted that she had been suffering from multiple gaps in memory over the last few years, and her family reported that her manner of behaving would change significantly at different times. When she had been told that she acted in a peculiar manner or that she had said some things, she was unable to remember any of these instances. She had had multiple experiences where she had injuries but was unable to recall how she had gotten them. For example, the client would take money from her father's pocket but would claim that she had found it. In these periods she was noted to behave like a child and much younger than her age. She would be highly suggestible and would call people names as suggested by a teenager who lived on her street. During one of the interviews, it was noted that Sasha was acting like a child, and upon enquiry she identified herself to be a 11-year-old who likes buying candies and treats from the money she would take from her father. She then seemed to talk about another girl who was often hurt by people at home and being harassed at work. It turned out that she was talking about herself, the 25-year-old. As described in the previous case example, the DSM-5 defines DID as experienced or observed dissociation in one's identity that is characterized by two or more distinct personalities or experiences of discontinuity in sense of self with changes in memory, emotional states and other psychological processes or experiences of possession. Sasha's lapses in memory that suggest experiences of dissociative amnesia are also a diagnostic requirement for DID in the DSM-5. The gaps in memory are not consistent with natural forgetting. This is the most severe of dissociative conditions and is usually accompanied by a number of other distressing symptoms such as depersonalization, anxiety, depression, self-harm, substance use, eating disorders, conversion and somatic symptoms and periods of unresponsiveness or disorientation. The severity or pattern of the condition varies drastically between individuals and time periods. It is diagnosed as a mental health condition only if the disturbance is not culturally or religiously normalized or cannot be attributed to imaginary or fantasy characters. The disturbances in an individual's identity experienced in this condition is frequently portrayed in pop culture as seen in movies such as Fight Club, Split or Black Swan. It is often incorrectly or inconsistently portrayed with the person switching between personalities extremely rapidly. The fragmented identity of the person can vary in number from 3 or 4 to even 100. They also vary significantly in terms of handedness, gender, sexual preferences and even biological factors such as skin conductance. These personalities are termed as alters, with a host identity usually being the one to seek treatment. The alters typically serve different functions such as generating income, seeking comfort, etc. The switch between identities, while instantaneous, is often dramatized or drawn out in movies. It had been reported to be strongly associated with experiences of severe early childhood abuse and reported more among females than men. The onset of the condition is usually in childhood around the age of 9 years. Other specific dissociative disorders. Other than the 3 main disorders described above, DSM-5 also provides a diagnostic criteria for dissociative experiences that lie out of those descriptions. It includes chronic and recurrent experiences of mixed or atypical presentations of dissociative symptoms such as did without experiences of amnesia or dissociative trance and possession. Trance and possession experiences are culturally or religiously prevalent in some parts of the world, like in India. These conditions are considered pathological if they defy cultural norms or are undesirable, especially if they involve the perception of possession by a spirit that is bad. 10.3.2 Etiology of dissociative disorders. Biological factors. While strong evidence is found to suggest that dissociative disorders are proximally and distally related to experiences of trauma, disorganized attachment and a number of other environmental contributions, the biological contribution to the propensity to dissociate has not been as significant. Some studies have found that the CANT, catecholomethyltransferase, gene is implicated in mediating the relationship between trauma and dissociative symptoms. A specific genotype of this gene was found to facilitate a link between increasing levels of dissociation in individuals exposed to higher levels of childhood trauma, and the opposite was observed with another functional genotype. However, further research in this area is required to understand the contributions of heritable factors that increase the vulnerability for dissociation. Sleep deprivation and fatigue have also been found to worsen dissociative symptoms, especially in the case of dissociative identity disorder. Psychosocial factors. From the perspective of the stress diathesis model, pathological dissociation requires the presence of both vulnerability and experiences that contribute to the development of a particular set of symptoms. The etiology of dissociative conditions is similar to that of post-traumatic stress disorder, where the symptoms and their severity are strongly linked with the nature and severity of traumatic experiences. It is widely accepted that the tendency to dissociate is rooted in a natural response of escaping from severe negative effect associated with severe abuse and trauma, including exposure to war and political conflict. Early experiences of emotional abuse were found to be the strongest predictor of depersonalization disorder in comparison with other types of childhood trauma. Dissociative amnesia and fugue states are found to occur more in response to severe life stress or trauma in the present rather than past experiences, such as legal difficulties or stressful situations at home. DID, being the most extreme of dissociative conditions, is almost always presented with experiences of physical and sexual abuse in childhood. The dissociative states of DID are hypothesized to function as a coping mechanism to handle the trauma of chronic or severe abuse, neglect and violence. These coping strategies are often not identified or treated in childhood, where fantasy is being used to deflect and manage aspects of the trauma and thus develop into dissociative personality states. Attachment patterns in childhood are also theorized to be a contributor to the development of DID, as experiences of abuse or neglect from the caregiver prevent the child from developing a secure sense of attachment and successful integration of experiences to form an integrated identity. Social and cultural factors are primarily linked with the clinical presentation of dissociative symptoms. It also influences perception of what we consider to be a pathological dissociative experience. In India, the most commonly presented dissociative condition was trance and possession disorders. It is hypothesized that the religious and cultural factors such as polytheism, belief in reincarnation and spirits that are more prevalent here contribute to this presentation being more common, and diagnosis of multiple personality disorder, currently termed as DID, being rarely diagnosed. 10.3.3 Treatment of dissociative disorders. Psychological management. Treatment of dissociative amnesia or fugue states is usually limited, as in most cases it is found that these states remit by themselves after a period of time. Since the onset of these episodes is clearly associated with stressful current life events, psychotherapeutic interventions with people who experienced these conditions primarily focuses on resolution of such precipitating factors and improving their coping skills. If necessary, the person is also enabled to recall and integrate information they are missing with the help of environmental cues and other people involved in their life. In severe conditions, which is often the case in dissociative identity disorder, a multimodal, trauma-focused approach is suggested by the International Society for the Study of Dissociation. This treatment guideline attempts to address the multiple dimensions of dissociative disorders such as affect disturbances, perceptual inaccuracies and comorbid symptoms of PTSD, anxiety, substance use, mood disorders, etc. through 3 phases of treatment. The first phase is focused on stabilization, as early experiences of trauma and attachment difficulties are often reflected in adult life through impulsive, self-injurious behaviors, and dysfunctional forward/abusive relationships. This phase focuses on addressing these safety issues and enhancing the patient's ability to cope with the symptoms. The second phase involves safe and adaptive processing of the traumatic memories to develop a coherent narrative and gain mastery over the memories. Developing the patient's self-efficacy is a major goal. In the third phase, patients are encouraged to develop a better understanding of their earlier difficulties in order to address its impacts on current and future life goals. The second and third phase is where integration of the different personality states in DID occur. Pharmacotherapy. Pharmacological interventions are not the first line of treatment for dissociative conditions, but they assist in stabilization and managing comorbid symptoms. Studies recommend the use of medication to manage the frequent symptomatology and mood disturbances to facilitate psychological interventions. The most responsive symptoms are affective disturbances, intrusive trauma experiences and hyperarousal. 10.4 Somatic symptom and related disorders. In the DSM-5, there are 5 major somatic symptoms and related disorders. These disorders fall under this umbrella as they have a common thread of preoccupation with bodily functions or appearance. Excessive, maladaptive responses to physical symptoms or health concerns to the extent of functional impairment are also a significant feature. In this section of the chapter, we will discuss the clinical features of these disorders along with their etiological factors and treatment strategies. 10.4.1 Somatic symptom disorder. This disorder was first named Briquet's syndrome, after the French physician who noticed that some of his patients came in with a number of physical complaints but did not have any medical reasons for the same. The current definition of somatic symptom disorder is given by DSM-5 as severe distress, persistent thought and excessive preoccupation with one or more somatic symptoms, i.e., physical health concerns for more than 6 months. This preoccupation is disproportionate and is associated with large amounts of time or resources spent on checking about their health. Based on the number and variability of the somatic complaints, and the nature of preoccupation with them, the severity of the condition can also be specified in the diagnosis. Often, the somatic complaint is associated with pain and thus this can also be mentioned specifically. To further understand the presentation of somatic symptom disorder, consider the case example presented in box 10.4. Suresh's concerns meet the criteria for this disorder given in DSM-5. He seems to be experiencing persistent somatic complaints though they seem to vary. They also impede him from performing adequately at work and he seems to be spending large amounts of time thinking about his concerns. Another common example of somatic symptom disorder is the experience of pain that is maintained or exacerbated by psychological factors, irrespective of the presence of a physical reason for the pain. This was previously diagnosed as pain disorder. The major point of concern in this diagnosis is not the presence or absence of a physical reason but rather the psychological experience of distress, anxiety or preoccupation with health. Box 10.4. Case study for somatic symptom disorder. Suresh, an office worker in his 30s, reported that he has been experiencing considerable backache in the last few months. He added that he has had a number of similar problems in the last few years but no one could clearly diagnose the reasons for them. He has been to a number of hospitals and has been on a variety of medication, but has not had any length of time when he felt healthy. He was extremely distressed by his recurring pain that were also making it difficult for him to perform adequately at work. He would either spend most of his time worrying about his health while in the office or he would take days off to seek help and recover. 10.4.2 Illness anxiety disorder. Formerly known as hypochondriasis, illness anxiety disorder is characterized by excessive concern with the possibility or idea of being sick. This is in contrast to the previously discussed diagnosis where the preoccupation is with the physical symptoms. Consider the following case example, box 10.5. Box 10.5, Case study for illness anxiety disorder. Raksha, a 40-year-old woman living in a metropolitan city and has been to a number of healthcare service providers in the last 5 years as she has been concerned that she may be having cancer. One of her close friends had gotten diagnosed with cancer 5 years ago when she had gone in to seek medical help for fatigue and abdominal pain. Raksha remembers thinking that since she is the same age as her friend, she might also possibly have cancer. As a result, she sought medical professions and investigations to rule out this possibility. However, she found herself being unsatisfied with the findings of these investigations that were turning out negative. This led to multiple and varied consultations to the extent that she has had a number of investigations done from blood screening to CT and MRI scans in this time period. She tends to go in for a consultation every time she finds herself feeling a bit tired or experiencing pain as a result of regular physical activity. Every day she examines herself in a mirror for any lumps or irregularities that may suggest cancer. Comparing the last two case studies, box 10.4 and 10.5, we can see that both are associated with fear and anxiety about their physical health. However, Raksha is less concerned with specific symptoms and focuses more on the possibility of a specific illness. She is likely to always be on the lookout for any indications of cancer, though she did not find any somatic concerns that are currently present. There is also significant distress and anxiety about her health. These factors, the lack of better explanation for her current concerns and their duration of 5 years, longer than 6 months, indicate a diagnosis of illness anxiety disorder. The majority of individuals with this diagnosis seek extensive medical care and yet feel dissatisfied. They generally tend to utilize a large number of resources for medical care such as health checkups and scans, to the exclusion of mental health assistance. However, a portion of individuals experience a paradoxical increase in anxiety associated with diagnostic tests and thus avoid seeking help even though they are distressed about the possibility of falling ill. It is also possible that owing to repeated experiences of unsatisfactory healthcare consultations where their concerns may not be taken seriously, they may not get an accurate diagnosis or treatment when necessary. Thus, the DSM-5 criteria also provide scope to specify the type of care-seeking behavior the person is engaging in. The illness that the person is worried about acquiring or having acquired might change over a period of time. Etiology of somatic symptom and illness anxiety disorder. Research on the pathological process of somatic symptom disorders highlights the role of heightened awareness of bodily sensations and the tendency to interpret these sensations as indicative of a medical illness. They are proposed to be disorders of cognition and perception that are associated with a strong emotional component amplified by psychosocial factors. It was found that the accuracy of understanding interoceptive cues, stimuli arising within the body that may be interpreted as signs of ill health, would deteriorate with increasing distress associated with the symptoms. Such misinterpretation is hypothesized to follow a sequence of steps starting with a heightened vigilance for health-related, an attentional bias to perceived threat to one's well-being. This information activates the individual's faulty assumptions and beliefs about illness and health, such as changes are indicative of serious illness, I should have no symptoms if I am healthy, and these symptoms might become a big problem if I ignore them. As a result, the individual increases their attention towards such symptoms and the cycle continues with cognitive, behavioral and emotional consequences such as increased physiological arousal, anxiety, preoccupation with concerns of health, checking and reassurance seeking. Genetic basis for the predisposition to distress associated with bodily symptoms was not strong in most of the research, however, they noticed a potential link between childhood adversities and increased bodily distress. This leads us to exploring the contributions of childhood experiences to the predisposition for these conditions. Attachment patterns with maternal insensitivity and insecurity were found to predict somatization as well as health anxiety. Individuals may also learn to be more vigilant of bodily distress based on modeling by caregivers in childhood. This could contribute to the development of dysfunctional assumptions or beliefs. Cultural factors also play a role in predisposing individuals to somatizing tendencies and focus on bodily distress. Management of somatic symptom and illness anxiety disorder. Recent research on the management of somatic symptom disorders has attempted to compile existing evidence on effective treatment, the unmet needs of the patients and the barriers to better treatment. In the realm of psychotherapy, it is important to establish a good working rapport, as these individuals are likely to have been to a number of health consultations and their concerns may have been dismissed. Engaging with them and taking their concerns seriously can help in further engagement in therapy. Providing ongoing support and reassurance was found to be helpful, provided it was delivered in an effective manner with sufficient time given to the client's concerns. Cognitive behavioral therapy, CBT, was found to be effective in teaching clients that physical symptoms can be induced by focusing on certain body areas and in helping them identify and challenge beliefs regarding illness and health. As the presence of additional life stressors may exacerbate symptoms, Enhancing coping skills and reducing stress can also reduce the frequency of care seeking. These can be targeted in therapy by identifying stressors, building active, practical strategies to manage them and implementing them. Reattribution therapy is one of the most frequently examined intervention that is carried out in 3 phases such as communicating understanding and empathy about their symptoms, beliefs, exploring possible explanations other than physical for the symptoms, and finally making a link between psychosocial factors and physical symptoms. It was found to be effective in engaging clients in therapy, though the effects were not found in the long term. 10.4.3 Psychological factors affecting medical condition. The significant feature of this disorder is the presence of psychological or behavioral factors that negatively affect a medical condition. These factors may increase the suffering, risk of death or disability, for example through their influence on adherence to medical advice, or denial of treatment. This can happen in the context of existing health conditions such as asthma, hypertension or diabetes, or it may also be associated with ignoring medical symptoms such as dizziness or fatigue. This is hypothesized to be a result of anxiety, depression, stressful life events, relationship styles and personality variables. They influence the physical health of the individual as they cause a strain on their available resources. The person might find it more distressing and taxing to handle their health concerns with the presence of significant psychological distress. This diagnosis is a cause for concern as one's attitude towards health-preserving behaviors can influence the trajectory of even severe conditions such as cardiovascular disease, AIDS and cancer. They may not take essential steps such as monitoring blood pressure, preventing secondary infections or regular intake of medications. 10.4.4 Conversion disorder, functional neurological symptom disorder. Conversion disorder was popularized by Freud's work on unconscious conflicts that result in anxiety that is expressed as physical symptoms rather than psychological symptoms. This condition is now diagnosed as functional neurological symptom disorder, as most individuals experience neurological symptoms, usually sensory motor impairments, that are not accompanied by other recognized neurological and medical symptoms. The absence of an attributable organic cause leads to this condition being identified as a functional disorder. Additionally, the term conversion carries links to a psychoanalytic theory about the etiology of these symptoms and thus will be removed from the DSM. To understand the clinical presentation of this disorder, we will look at the case example presented in box 10.6. Sona was found to have loss of sensation in her legs, in addition to other physical ailments that were presented without any identifiable medical condition, as the symptoms were not part of any particular syndrome or have any positive findings on diagnostic investigations. Other commonly seen presentations in this condition are mutism, loss of sensation in other parts of the body, paralysis of certain parts of the body, tingling sensations, loss of vision, seizure-like episode and sensation of a lump in the throat. Most individuals with this condition are able to use the affected motor and sensory symptoms unconsciously in emergency situations. Box 10.6, Case Study for Conversion Disorder. Sona, a 15-year-old high school student, was admitted to a general hospital with flu-like symptoms which proceeded to persistent vomiting and nausea. As investigations ruled out possibilities of any infection, she was discharged from the hospital after 2 days with medications to manage the symptoms of nausea and vomiting. In the next few days her condition seemed to worsen, with her legs starting to feel weak even if she was standing for a few minutes. She was then evaluated by other specialists such as cardiologists, and no organic causes were notable for her symptoms. Over the next 2 weeks her symptoms seemed to grow into numbness of legs and being unable to get up or stand without aid. She was then referred to a neurologist. While no biological causes for her symptoms were found, it was noted that she grew up with her father being physically abusive towards her and her mother until the age of 13 years, when her mother divorced her father and they moved to a new city. A few months later they moved again to live with her maternal grandparents and had to switch to a new city, school and living environment. One of the controversial aspects of conversion disorder is the possibility of the conversion reactions and symptoms being a result of an undiagnosed physical disorder or even being faked by the individual. Initially, an attitude of indifference towards the symptoms, called labile indifference, was considered to be an indicator of conversion disorder rather than a physical condition. However, it was later evident that even in cases of actual physical disorder, a number of patients displayed indifference to their symptoms. Other factors that may help in correctly diagnosing conversion symptoms is identifying the presence of precipitating stressors and sudden remission or utilization of the lost sensory or motor function, such as being able to dodge an obstacle though they may report being unable to see it. It is also important to distinguish conversion disorder from malingering, i.e. a person intentionally faking symptoms. Malingerers are fully aware of the difficulties they are faking and usually do so in order to manipulate others and to obtain some gains. 10.4.5 Factitious disorder. Another psychiatric condition that needs to be discussed here is factitious disorder, a disorder that shares features of both malingering and conversion disorder. The symptoms that are reported by the individual are under voluntary control in a manner that is similar to malingering, while there is no obvious reason for the person to be displaying these symptoms other than increasing attention by assuming a sick role. This is similar to conversion disorder as possible secondary gains from being identified as the patient is considered to be a maintaining factor. A more concerning presentation of this disorder is one in which the sick role is extended to other members of the family, especially a mother presenting her child as sick. The adult usually engages in deliberate acts to make the child appear sick by faking test results, or they may even induce injury or illnesses. This is called factitious disorder imposed on another. This atypical abusive behavior lets the individual gain attention they desire and is also known as Munchausen syndrome by proxy. Etiology. Functional neuroimaging studies on individuals with functional neurological symptoms suggest that abnormalities in processing emotions can serve as a vulnerability factor, while differential reaction to different stresses or trauma can occur. However, this does not lend itself to any particular theoretical explanation of the symptoms. Psychoanalytic theory proposed by Freud describes 4 basic processes in the development of conversion disorder. He proposed that when a person encounters an unconscious conflict that is unacceptable, the person experiences anxiety which cannot be expressed in an appropriate manner and thus is repressed from conscious experience. The anxiety continues to increase and threatens to enter consciousness. It is converted into physical symptoms and thus the anxiety is alleviated. This process is reinforced by the presence of positive outcomes from assuming the sick role, known as secondary gains. This includes increased attention, avoidance of conflict or problematic situations and sympathy. From a socio-cultural perspective, the varying incidence rates of conversion disorder across societies and nations also provide evidence regarding factors that can contribute to its etiology. This condition was found to occur more in less educated and poor socioeconomic backgrounds. In these populations, knowledge about mental health and illnesses is not well developed. Further, these disorders were found to be decreasing over the years, suggesting that better knowledge and understanding about health and well-being may serve as protective factors or mitigate the vulnerability factors. Management. A recent systematic review of the effectiveness of psychosocial interventions in the management of conversion symptoms found that the available literature is relatively small. They noted that a broad variety of interventions such as behavior therapy, cognitive behavior therapy, hypnosis, paradoxical intervention and psychoeducational have been applied in the management of conversion symptoms. They did not find any strong evidence supporting the use of any one particular intervention. The authors suggest the integration of patient preferences, values and background information to decide on appropriate interventions. A commonly used intervention strategy is to identify and resolve traumatic or stressful life events. Addressing the secondary gains and reducing their reinforcing properties is another important aspect of symptom management. However, this might be difficult as it often involves participation of other members in the intervention, such as parents being involved in the management of conversion symptoms presented by children. Additionally, hypnosis and CBT was found to be associated with improvement of symptoms for 60 to 65% of the participants. 10.5 Let us sum up. Dissociative disorders. Dissociative disorders are characterized by loss of continuity in experiences or memory, sense of identity, and distorted perception of oneself or the environment. 3 disorders classified under the dissociative disorders are depersonalization derealization disorder, dissociative amnesia, and dissociative identity disorder. Stress diathesis model is often used to understand the etiology dissociative disorders. According to this model, presence of both vulnerability and stressful experiences contribute to the development of a particular set of dissociative symptoms. The tendency to dissociate is explained to be rooted in a natural response of escaping from severe negative affect associated with severe abuse and trauma. Early experiences of emotional abuse, sexual abuse, violence, severe stressful life experiences, childhood neglect, are implicated in the development of dissociative disorders. Treatment of dissociative amnesia or fugue states is usually limited as in most cases it is found that these states remit by themselves after a period of time. Since the onset of these episodes is clearly associated with stressful current life events, psychotherapeutic interventions with people who experienced these conditions primarily focuses on resolution of such precipitating factors and improving their coping skills. If necessary, the person is also enabled to recall and integrate information they are missing with the help of environmental cues and other people involved in their life. A multimodal, trauma-focused approach is suggested by the International Society for the Study of Dissociation. This treatment guideline attempts to address affect disturbances, perceptual inaccuracies and comorbid symptoms of PTSD, anxiety, substance use, mood disorders, through 3 phases of treatment: stabilization, safe and adaptive processing of the traumatic memories and development of self-efficacy. Somatic symptom disorders. Somatic symptom disorders share common symptoms such as preoccupation with bodily functions or appearance, and excessive or maladaptive responses to physical symptoms or health concerns to the extent of functional impairment. A majority of individuals with these disorders seek extensive medical care and yet feel dissatisfied. The disorders classified under this category include somatic symptom disorder, illness anxiety disorder, psychological factors affecting medical condition, conversion disorder and factitious disorder. Etiological factors include heightened awareness of bodily sensations and misinterpretation of bodily dues in these individuals, attentional bias to perceived threat to one's well-being, faulty assumptions and beliefs about illness, which results emotional consequences such as increased physiological arousal, anxiety, preoccupation with concerns of health, checking and reassurance seeking. Attachment patterns with maternal insensitivity and insecurity, and socio-cultural factors are also found to play an important role. The psychological interventions emphasize on establishing a good working rapport with these individuals. Engaging with them and taking their concerns seriously, providing ongoing support was found to be helpful. Cognitive behavioral therapy, CBT, and reattribution therapy are found to be the most effective therapies in somatic symptom disorders. Additionally, resolving traumatic or stressful life events, addressing the secondary gains are also found to be the important components of the psychological therapies.